that something's wrong there. He's consistent.
I think the rationale was, just as Neil was saying earlier, you can be a vasculopath, have type 3 arch, challenges, tandem lesions, and so that's process independent, right? That's more operator specific.
If I could make my money, I'd rather than connecting 3 different anti-stroke skills, having groin skin puncture and having a final recovery time. I think that's
Right, I mean, that's the thing. Yeah.
So I'm all for it. I think if there's a mechanism to get with the guidelines moving forward with the update to collect that, then we can, and then define, you know.
Justin says yes.
They do, and they ask it to.
Yeah, I thought they put it back in because
I think it's in the tool.
Okay.
It's not maybe
It's in the CSC tab.
It's not mandatory. It's not mandatory, but we can make
So
it.
we will add final reperfusion time as a
Yeah.
metric, and you know the definition isn't intuitive, but it's basically once you're done with all your passes, it's what's the final time of reperfusion, the final run time.
But I think there's a little disadvantage there because if you have a population of 90 plus year olds or 80 plus, you know, it's the anatomy is not favorable of
That is actually not scientific. There will be some data coming out on that, but that's actually not true because the 90-year-olds have more cardioembolic stroke. They actually have a higher chance of having first pass repeat. They have these big badass clots that you pull out, and they don't have longer reperfusion time. So that is sort of a theoretical, but actually not practical concern. And I think in the end, it comes down to you have to have both metrics. The hospital system would be penalized for having bad door skin
I agree
puncture.
with that.
The rest is kind of like gravy.
I would second her concerns though. I mean, people have already walked this path before, right? And they were backing off on that metric. So there's a reason for that. And I think we should, look into that a little bit more in detail. They already tried to collect that and it wasn't really working. And they had to backtrack. There's probably some reasons behind that.
Yeah.
I think part of it is the difference between door to first pass versus door to final recanalization. How do you consider first pass? How is it documented in the procedure notes? So it was really difficult, and I think there was a discrepancy between how different hospital systems were collecting those data. And so it makes it much more difficult. Groin puncture or skin puncture is skin puncture no matter what.
Right.
But there's a lot of gray area between what is first pass or recanalization.
But argument from a patient standpoint, if your provider takes 2 hours every time because they need to do a full angio first and then they need to work their courage up to go up there, that is not going to help their functional outcome. So you want to measure when is the brain reproduced, when is it done. And that's sort of a metric. And
That's going to be captured on your outcomes data though. That's going to be captured on your outcome data finally.
Or
Yeah, I think,
wouldn't something more clinically relevant be than symptom onset or last time known well to full recanalization or full reperfusion?
no, because you
That's right. That's independent of the hospital.
No, I understand that, but I mean as far as clinical outcomes for the patient and patient outcomes,
Yeah, I agree.
I feel like that's more clinically relevant.
I say both metrics are easily available and both should be captured if we can get them.
Yeah.
I think it's going to be messy though.
Yeah, the issue with symptom onset is you have rapid progressors and slow progressors. So there's sometimes not a direct correlation between, when the patient actually had the LVO or small vessel stroke and after treatment. But, I think the volume of averages is good to collect and then see what the pattern shows us.
If we can, we gotta know which hospitals are having advanced stage interventions. I know FMC, Holy Cross, sees a lot of advanced stage patients. No, you disagree?
I don't do advanced age patient. I'm going to have to change my pattern based on some of the upcoming data, but no, if they're over 80, I'd go like this.
But we've had some really good outcomes.
Some really good. We've done 9.
Yeah, we have too.
I mean,
I'm really
Change
not
my
worried
mind.
about that.
Well, I'm saying, after change, I've seen some of the data change
yeah,
my
we've had some really
Yes.
Can we just backtrack it just for my own, because I need to know kind of like what are we calling an intervention? I think I'm not quite clear on that at this point. Is it intervention when we actually go up and retrieve a clot, or is it past drawing puncture? Are we including all those people as an intervention? Because I think that's a really important point.
Yeah, so
because it's
at
gonna
least
change
any
the
patient that has an LVO and the intention to treat with mechanical thrombectomy, you take them for groin to the cath lab. The time of groin puncture, at least by definition, because of the issues with microcatheter cross clot versus what device, if you're aspirating versus deploying a stent retriever,
What if you take
I
a
think there was
patient?
a lot of discrepancies.
Yeah, what if you take a patient to the cath lab but they don't have an LVO, and you don't intervene?
And they're going to have a good modified ranking, so
Yeah.
you
don't call
keep
that an
doing that.
intervention.
So then that's not an intervention.
Especially if they've had TPA.
No, the abstraction questions are worded and structured in such a way that it's very clear if the definitions are there. If it was an actual MER, there's even an option for you attempted to reach it and you couldn't, or if it was angio only, it's all baked in there. They're very specific.
So no LVO gets excluded.
Yeah.
Correct.
So I'm concerned that the whole process is really skewed towards really going fast, and it doesn't matter whether the patients have an LVO or not. Just go to the lab and make the process fast versus actually taking the time to figure out, will this patient benefit from what I'm doing, and am I putting that patient at any
Yeah,
additional
so
risk?
that's why it's good to
That's
segment
what-
out, and I have a slide on that, and then we'll wrap up. So I completely agree with you. We don't want to go, super fast without thinking on every patient, especially if they have a fluctuating exam and a M1 occlusion, despite an M1 occlusion, if their NIH is only a 2.
Exactly.
And so that's a thoughtful approach where you discuss with the family the pros and cons. And some people will perform the treatment based on family's input, and others, may not, because the patient may be completely back to normal and not BP dependent or anything. And so when we wrap up, there's a rationale for generating 2 dashboards per hospital in terms of those that meet the guidelines versus treatments performed outside the guidelines, because we don't want hospitals to be penalized for going slow in a patient that has an NIH for stroke seals 4 or 4, right? I mean, that would not be reasonable. Okay.
Let me just interject. Medical marijuana is legal in Florida now.
It's heavy, busted out.
And Trump is leading Clinton in Florida. Just
Get out your script, man.
Okay, so treatment rates, I promise I only have a couple more slides. So total number of stroke alerts by quarter, we had discussed this. So, and then the treatment rate that can be generated, for IVTPA, thrombectomy volume by quarter, and then number of LVOs diagnosed versus treated. So this all goes to the, sort of understanding of a high volume stroke center versus low volume, if that has any impact on favorable outcomes. The data shows that there is a correlation, but we can look at our own numbers. What is the definition of high volume versus low? In the studies that were done by Gupta and others, it was defined as less than 50 cases versus more than 50, or less than 25 cases. I have to double check. But I believe it was less than 50 versus more than 50. And so, we can basically dichotomize, our own volumes and say, look, among centers that, may not have a lot of thrombectomies or overall number of LVOs, is it because they, are under-treating despite seeing a high number of LVOs, or are they just not getting enough through the door, right? So I think that type of data is invaluable. Do you all agree with the rationale for looking at this?
Right. It's just very difficult. The number of LVOs diagnosed, I'm not sure that reliably makes it against the guidelines, because we've been talking about that.
Yeah, so at least the LVO piece, right?
I don't think
It's
it's
difficult to get the exact number. I mean, what are you going to base it on? And we don't have CPAs.
Yeah.
So there's a lot of
No, so
research.
exactly, on the patients where you did the multimodal imaging.
There might be
There might be-
places who are not as aggressive.
Right. So you only
to
do
not
10%
have
of
any
yeah.
Sure. So, but that will reflect on the overall denominator too, right? Like they only had 10 LVOs diagnosed for a whole year.
Right, but I mean, again, would it be fair to even go? I mean, again, it's probably a difficult discussion, but if you cannot quantify the denominator properly, then even the numerator does not matter. And getting that exact definition of the denominator is very difficult. They extrapolate it by using the total number of strokes and saying that you have like an uncanny higher number of small vessel strokes as opposed to LVOs. But again, that would be population dependent. Again, northern market, there are older patients.
But I think as a most usable and fair measure, and that's what the Florida Puerto Rico Registry has done, is you just use the overall ischemic stroke excluding TIAs, benchmarked against the number of interventions. The problem with that you have is that there's actually a unfortunate intrinsic incentive to be over-treated because A, you get paid for it, your team's already there, and you don't necessarily know whether it creates better outcome, but whether these patients have already a good outcome, but in your 90-day outcome cohort of interventional patients, it will create a better outcome. So it's a triple benefit to over-treat, and that's I think one of the concerns that we have is so as EMS, you really have to constrict it to like what Rajesh said, you have to have it to the on-label kind of cases. Look, how did those do? The M1, the M2, the
And this is not something we need to finalize by January of 2017, but this is, essentially up for discussion in terms of how do we want to look at this when it comes to examining high volume versus low volume centers. Is it a benchmark nationally? What's the thrombectomy rate, TPA rate, versus what is it locally here? Without even looking at the denominator, right? Is this what are all the treatment rates? That's it.
I agree that
To
the
keep it
number
simple.
of LVOs is difficult to define.
Right.
How long after, for which population, people who got imaging later. I mean, it's just pretty messy.
No, absolutely. I agree. So these are the outcomes. Any questions about this? So discharge modified Rankin, 90-day, and then the symptomatic intracerebral hemorrhage rate.
So wait, I just got that because we discussed it as part of the registry. What is our definition for symptomatic hemorrhage in the guidelines?
Within 36 hours, accompanied by a change of MRS to the worst of 4 or greater.
NIH.
NIH, what did I say?
4 or
Right.
more.
I'm sorry, NIH.
So the problem is some of them use PH2. I don't think we should use this. Because
No,
it
that's
doesn't
from
matter-
UCAS 3.
Exactly. So you
Yeah.
should have any hemorrhage and an extra scale of 3 or more than 3. The problem is, what do you do? Some of those hospitals have a high utilization of anesthesia and some of those patients.
All right.
What do you do with those patients?
Yeah, I mean, there's going to be outliers, and I think that information you can enter into the database in terms of why that metric, data was not available at 36 hours, so that it doesn't appear as a fallout. Okay, so these are the outcomes. So we'll move forward. Okay, so standardize the treatment selection, right? So this is what some of you were talking about. So we want to make sure that all PSCs and CSCs treat patients with IVTPA based on the latest inclusion-exclusion criteria, and that all CSCs manage the LVOs based on published ASA guidelines. Anything done outside of those guidelines can be looked at, but not in a punitive way, as we were discussing earlier, right? And so, that would result in essentially segmenting out into 2 different dashboards, within guidelines versus outside guidelines.
But I want to just caution you, FLPR registry right now has no capability of differentiating between a patient who got TPA with a platelet count of 95,000
Right.
off-label or 110,000 on-label. We can't do that. It's too coarse of a tool. So
In terms of the lab values.
we don't have a way to figure out who was treated on label or on the
Yeah.
scientific guidelines or on
Right.
whatever they are.
Yeah, I agree, but for mechanical thrombectomy, I think is easy to parse out based on just a last known well time. and the NI stroke scale score, right? I have listed 3T aspects, assuming that's something they would be able to collect, but we can remove that. And
So wake up strokes, all that would be on a separate dashboard.
correct, exactly. So I'll just give you an example. These are two comprehensives, A and B. Comprehensive A is conservative. They both see the same number of LVOs, 100 LVOs, keep the math simple. 50 met the guidelines at the door, okay, on arrival. 50 did not. They treated 50 patients that were all within the guidelines, published ASA guidelines. So if you look at the 90-day outcome, it should be somewhere around 55 to 60%, right, based on the trial. So yeah, they come in that spectrum, okay, 60% good outcome. Now you have comprehensive B that tends to be more aggressive, same number of LVOs, but they treated those that were outside of guidelines as well. So they not only treated the 50 within, but also the 30 that might have been wake-up strokes or, you know, MRS of 2 or 3, whatever. And so the good outcomes here, because the whole thing got diluted, the denominator, right? And that's what my NCOL published as, you know, the policy, is the outcomes were 50%. So even though they're more aggressive and the good outcomes for these subset of patients within guidelines is the same as that one, they get dinged, right? So this is the rationale for segmenting out into two dashboards, because, you know, the 10 patients that they did treat benefited, those 10 outside the guidelines. So I think we just have to report that separately, and the way to do it is like this. So at Mass General, we had the likely to benefit patients and the uncertain to benefit patients. And so I think based on, again, published guidelines, we all agree that, look, you know, as you were referring to, if they meet the current guidelines, their stroke scale is high, they're within the 6-hour time window. The most recent JAMA paper found that it's actually, you know, up to 7 hours, almost 8 hours, which is, I think, going to eventually be the new guidelines within 8 hours. But until those come out, I think we all agree that these are the patients where we move quickly, okay? For all others,
If we had a different candidate right now, we could go and have a single payer system and figure out that we have one metric, and that is dollars spent per one patient with good modified ranking score 0 to 10.
right.
That would
But
be
we
the
don't have
ultimate.
that.
Yeah.
Right now it's Clinton 97 to Trump 84 electoral college, just so you know.
So can you go one slide back?
Yeah.
Oh yeah, okay, so move forward.
Sorry.
Sorry, I missed it. So
That's okay. So these are, you know, it's using your judgment, but also published guidelines, right? Clinical and your radiographic. So this is matches what's published. Okay. So you guys can use this for your reference, you know, when we send this out, because I think this, in and of itself, addresses some of the variability we see, because, you know, the stroke neurologist or the general neurologist, most hospitals don't have stroke neurologists down here. And so the general neurologist may not be up to speed with this. They may not know, okay, should I call my interventionalist for this case or not? And so if you have an established protocol that whether the patient goes to Mount Sinai or to Baptist or wherever, they're going to get the same level of rapid care, right?
Is Dr. Sacco's group able to do that?
Yes, because if you collect upfront clinical variables, the last known well time has a time point, and the NI stroke scale score, then you can easily generate that.
Anything out of the guidelines should be created separate dashboard.
Exactly, right. Okay. And then these are uncertain to benefit, so the mild deficits, NIH less than 6, the really old patients, the nonagenarians, and then pontine strokes, things like that, fall under this umbrella. Okay.
Can I just ask a silly question? Anybody here treat moderate or severe dementia with embolectomy? Severe dementia.
Severe? I mean,
Moderate.
Go by the MRS.
I mean, to me, if somebody mentions the word dementia or mentions the word
But
nursing
what
home,
is-
I'm out. I'm done.
Yeah,
So-
the
But
problem
what
is
is
you
the
don't know when you
MRS
stop.
for? Like if they're ambulatory and they're.
Ambulatory is not a
Look
quality
at
of
the
life.
MRS.
so that brings up a good question. How many of you are collecting baseline MRS? Like, as an interventionalist, we're logging it in our, sheet that gets scanned in, that baseline MRS is this, if family's available.
Well, we impute it.
MRS, we only collect it once at the time facility at FMC.
After the treatment.
It's usually after or
Right.
sometime during the admission.
Yeah.
I mean, the question came up today because there was a debate about whether to take the patient to the lab, and I did not have the MRS to refer to.
Sure.
I had to
We use our judgment, like this patient's nursing home, demented, we're not going to take them.
Well, I
But,
discussed with interventionist comorbidities, and she has several comorbidities that were limiting.
right. I mean, I think and again, this is my opinion, that it would be great to have some type of a quantifiable baseline data. So, again, if we look at hospital-wide outcomes in a region, if one territory is getting a lot of really old or comorbid patients compared to another hospital, then they will get unnecessarily dinged, right? I mean, there's got to be some mechanism.
I think that there's a classification of dementia where we see them and they're not, really that
But it
demented.
depends on functional.
Yeah,
functional
status.
status. It is dependent on functional status. I mean, that's why.
But if
it's
they're
important
able
work
to
that.
walk and they're somewhat independent, even if they have dementia, treat them.
Right.
I mean, I'm a much tougher adjudicator. It's like, okay, so if you're obviously needing assistance, you're already costing public healthcare dollars, and now you want us to spend additional healthcare dollars to get a couple of additional months or years out of that, versus going to hospice. It's very hard to make that argument.
There's a lot of
So, I
cultural
mean,
components to it.
You might be going on a tangent here.
There are some families that want them to make
If you're
their
91 and you
95th
keel
birthday.
over in your Ferrari
Because
golfing,
they have a party
it's no
planned
brainer.
already.
Yeah.
No, because they have a party planned already for the 95th birthday, and they're adamant. And
Yeah, no, I don't disagree, but that's why we're at 18% of the GDP on healthcare. Like, they would do that in
But
Canada.
it's not a call.
So-
Exactly. I'm not saying
Right. But again, that's an area where there's a gap right now, not just in South Florida, but across the country in terms of, if you're not conducting a clinical trial, how do you, consistently collect that baseline information? And I think in a practical sense, just like you mentioned, is challenging. When the family may not be there, and you're getting scattered, limited information from EMS. So sometimes just the facility or place of origin might be helpful. Assisted living, nursing home, or home, right? And that in of itself could be a proxy for baseline MRS, but we can put that out there as a suggestion.
But is it that important to collect that prospectively at the time of the encounter? Or that's something that can.
You can do a retrospective.
Yeah. So
Yeah.
so a lot of this is not a big problem. I mean, usually that's information that can be ascertained at some point.
Yeah, it's just if we're talking about creating two dashboards of within guidelines and outside guidelines, within guidelines it would be great to have the baseline functional status.
So that's not good as an MRS though. Within guidelines, that's an MRS.
Correct, yeah. And for us, it could be the place of origin, and if it, anything assisted living or nursing home, that goes into category
Dr.
2.
Ultimately, what we're going to need is a randomized trial. See, what is the number of dollars needed to get one person over and that's for to get back to functional independence, and for how long?
So that's all we have, and I hope this discussion was useful for you all. And none of this is in stone yet. Amongst us, as the core group of interventionalists that are present or on the line, I think we can meet. Again, not in a dinner sort of environment like this, but just informally. So our group is going to keep getting smaller to achieve sort of the final. Consensus on for the data collection of the variant.
I have one question.
Yes.
You didn't touch about sampling. What would be expected? 100%?
Yeah, so we asked that earlier.
Okay.
And we're
My
gonna
apologies.
ask the registry folks that what would be their sort of reasonable sample.
I think from what I understand from Dr. Romano, is no longer sampling. I think they're abstracting 100%. So, I don't know if Maria's still on the call.
Maria, are you still
So
on?
how do we reach 100%?
Of like data abstraction, every stroke gets together with the guidelines done. Maybe we could do 20 or whatever, like some random samples, because they had so many, but I think they've changed.
Any other questions?
There's one last point, and I know it's not so much for the intervention, but I don't know how much you're weighing this. Is this going to be strictly intervention?
No, this is TPA and or thrombectomy.
All right, so it's just TPA.
And looking at
or-
PSCs and CSCs.
Okay. Well, some places enter their TIAs and some don't, but the TIAs wouldn't be receiving TPA, so it wouldn't have any bearing.
Some TIAs do.
Yeah, I mean, if it's a fluctuating exam, but
If they
ultimately,
have an
if it
MRI,
gets
it's
quoted out
negative.
as no stroke because of MRI's negative.
Well, wait a minute. Because usually once they get TPA, they will not ICD a TIA, and the argument is you prevented the damage with the TPA.
So that's why all the mimics get coded as stroke.
Yeah.
We get coded as stroke on all of that.
Very true.
Yeah, TPA should never code as TIA.
Otherwise you don't get paid.
Yeah.
No,
I
I was
didn't
just-
say that.
I was-
Dr. Mueller said
I was just
that.
elaborating on the definition of a TIA when you mentioned that before.
No, but I mean, I think that's one of the concerns.
Yeah.
But
Right.
at the same time,
Attributed to the treatment.
look at the greater good. So if you treat a TIA or mimic with TPA, you may overtreat. The risk of bleeding is very modest.
Yeah.
And I think overall, contributing to the rate right now, we all agree that TPA is grossly overpaid. Why did we go up 300% since stuff is approved? I have no
Yeah.
idea.
Because their patent's going to run out.
Well,
Well, they
TPA,
should run out now.
TPA costs the same as a stent retriever.
Good, that's
you know?
ridiculous.
Yeah. So that's
Not
food
for
for
much
thought.
longer.
Right.
I'm hoping.
Well, inpatient TPA, the same formula as outpatient TPA, the costs are drastically
I can
different.
tell you, in Germany, the TPA, 100 milligram dose is 1,600 euros. So, 1,400 euros.
But along the same line, then why not take most patients for embolectomy? I mean, wouldn't the false positive diagnostics, or so to speak, they would be the same just like stroke mimics? What's the harm from embolectomy? 0.01%.
Yeah, and the risk of bleeding in all the interventional trials was lower in the embolectomy group than in the TPA group.
Right.
So, I mean, that's a valid argument you've made. Is the cost of TPA offset by smooth
That has to go in.
But I think that's the
Standard.
big question, right? Hopefully the next trial will answer.
There's not going to be a trial like that.
Really? Swift that?
Swift direct?
Swift direct.
I think there's more likely to be a trial looking at that than some of the other things you proposed, to be honest with you. Right?
I don't think it's happening, though, because there's no benefit of the company.
So I think we'll wrap up. Thanks everyone for your time and feedback. I think the discussion was excellent. And starting in January, we'll have the stroke workshops. Laszlo from Holy Cross will send out the series of topics, and I think it'll be fantastic. This is sort of the overall realization of the vision that we've had for the last few years. And I'm very excited at the impact that's going to have on patient care. So thank you all for being here, and hope you have a good night.
Thanks.
Is it okay if we just do like some housekeeping stuff and just go, everyone say who they are, where they're from, so I can just document that and all that? And then also I want to know what the next steps are regarding these data points as far as how we're going to kind of finalize those as well. So, want to start?
Yeah, Dave Roberts, the number.
Yeah, just read that through the straight.
Okay. All right.
Sorry.
Okay.
John Shalhoub, no sign
Say it's about our last name.
CHA.
Okay.
Are you a neurologist?
I'm kind of a hybrid.
Hybrid? Okay.
Hybrid in what sense?
I have background in radiology and neurosurgery.
Okay.
Louis Moreno with the number.
Moreno.
Oh, I see. Could you
Okay.
put it in as a CTA break?
Felipe Rios Vázquez.
Los Rios.
Nelo.
At 6 a.m.
Yeah. And you are an interventionalist?
No, neurologist.
Correct.
Okay.
Amy Starosia, I'll spell that. Starosiak.
Wow.
I'm the research administrator for Baptist.
Research admin. Okay.
Don Trey Williams, stroke coordinator, Mount Sinai.
DAWN.
TRAY.
Stroke coordinator.
Mount Sinai.
Mount Sinai. Okay.
Annie Ewan, spelled Y-U-E-N, radiologist, Mount Sinai.
NY?
No, Y-U-E-N. Yeah,
Oh,
no
okay.
N's.
And you are the what again?
Radiologist, Mount Sinai.
We have a big Mount Sinai showing today.
Ryan Dahlgren, DAHLGREN, neurologist.
Ritesh Kaushal, interventionalist from Meadow.
Can you spell your last name?
Kaushal.
Your restaurant's at.
From Meadow.
Okay. Next. Kim.
Kim Harris. I'm a nurse practitioner at Holy Cross with Dr. Wolfie and
Okay.
Justin Boise, stroke coordinator, Holy Cross.
Okay.
Michael Obzut. Do you want me to spell that?
No, I got it.
You got it.
Okay.
Basically, I'm a neurointerventionalist.
Chantal Gaudreau, stroke coordinator at CCF.
John Panic, EMS chief, Pembroke County Fire. John Cunha, Oakland Park Medical Director, EMS.
Ms. Mueller, regional director for
So where did Brajesh go? So as far as next steps of getting all these points finalized, what's the thought process on that? Who's going to be involved in charge of that?
I think a lot of it can be done offline. Coding on the data points, you agree, yes, no, with a simple
Yeah, I think it'd be great if we can get all the interventionalists together, like for a meeting. It doesn't, just somewhere, and we can kind of all talk together.
You think it has to be face to face?
It doesn't have to be face to face. No, a couple of people can be face to face. I think it's hard to get face to face, with all. But if we can coordinate that, that would be awesome.
What I'll do is I'll task kind of Brajesh with that, so that he. I mean, are you guys all on a listserv? Or are you guys all in some? Are you guys connected in some way at all?
This meeting,
Yeah.
This meeting.
Okay. All right. So, but as far as email addresses and so forth, you guys.
You have all of them.
I don't. Laszlo, do you have everyone's email address? As far as everyone
If everybody put RSVP, right?
You send me that list and I'll check because I have a list for email addresses. I have a list for RSVP, but the two not necessarily match. I have a couple of people who RSVP'd and I have no idea about the email address because someone else wrote the name on it.
Okay.
So first of all, I wanted to give a shout out to Laszlo for organizing.
Yes.
I think it's absolutely
it was awesome.
Thank you. And then I wanted to give a shout out to this group because people don't realize how cutting edge Florida is in getting this shit done.
And we are the ones that
We are
care.
the one that develop
We are the ones that care.
stuff
We showed up.
for the rest of the nation. So I
And
think-
everyone's watching, I must say.
Right.
I mean,
Everybody's really looking at Florida. We are setting the EMS, the system of care protocols for the rest of the nation. So I think we should all be very, very proud that we're in that position to be care.
And the second thing I'd like to add to that is, we are in a very unique geographical area where we have all these comprehensive stroke centers, and in the end, I think you know, maybe the question, like, I think the awesomest thing is that we're collecting data to figure out exactly what's going on. So I think, you know, I really have to, I came here only a year ago, and this has been already in the process for a long time, but I completely support it 100%. And then I think, you know, down the road, obviously this is going to be like a much more involved process, but I think if we end up not just in competition, I think competition is very healthy, but in the end, you know, if we can give EMS a lot of options, you know, and a hospital that is, for example, busy doing an intervention, you know, and is able to maybe through some kind of an app, like a Pulsar app, like say they're busy, and then have the EMS, you know, give them online information like this, and we can all cooperate together. I think that's going to give us the best actual, you know, benefit for the community, which is why we're here to begin with, you know, is actually to treat patients. So.
I agree with that. We tried to do that about 4 years ago in Miami-Dade, so maybe this time we'll have more success.
Well, I think that the regionalization of care, and again, Sarah is just one kind of item, but I think that having all of you guys in the room and having all the hospitals participating, I think for me, you know, someone who experienced my grandfather having a stroke and not getting good care, and as a medical director, I see we transport to 9 different hospitals, and the fact that I don't know what happens after we drop off the patient is just, it's very disastrous for me. And unfortunately, I have to say, in Broward County, there's 24 or so municipalities who all operate independently. If you ask them how they do for cardiac arrest, stroke, trauma, they all tell you we do pretty good, but they don't really know their real data. And Miami has less kind of agencies who transport to fewer hospitals per se. But if you're on the inside of the EMS view of it, nobody knows what's going on. And it's really sad that we all, you know, very smart people in the room, and who cares the most, by the way, are the paramedics, it turns out. It turns out that the paramedics know that where they're going, if the care is good or not. And they know that because they just have that sense of what's going on around them. They see how the response is, and they're very excited about what we're doing here. And so I would hope that over time, that over the next year or so, that if we can all band together, and you know, again, I'm a medical director in Palm Beach, Broward, and I'm also an American Ambulance, I'm also in Miami. I would hope that we can get the Tri-County area together, all as one, and kind of compare against each other to help ourselves rather than to compete against each other. And so the people in the room, I would say kudos to you for showing up. And the people who are not in the room, I think that at the end of the day that they're going to suffer. And again, you know, and maybe I'm speaking for John as well, but am I prepared as a medical director to say I'm not going to take my patient to a hospital who's not willing to give data? Hell yeah. You know, I mean, I think that that's probably a tough political place to be in, but I'm ready to do that.
And I wanted to give great praise to all the medical directors, but especially to Peter on that, because Peter, how long have we been working? We've been talking about collecting data for at least 5 years. 5 years.
Since 2012.
And there was a medical director, you know, that we competed with for the longest time. We couldn't get it done.
Yep.
And finally, you and Rajesh broke through that logjam, and I want to give you great credit for that, because this is what we need. We cannot improve what we do not measure. If you don't measure it, you don't know what it is, you can't improve it. So data is the new currency. We need to get there, that we have, you know, that mindset.
What I would say to everyone in the room is that if you're a neurointerventionalist, a neurologist, a stroke coordinator in a hospital, reach out to the EMS folks, because the breakthrough was the fact that Laszlo and Nils and Rajesh come to the meetings, and once EMS recognizes the fact that the hospitals are hand in hand, then that's kind of like a lockstep, and we can move forward. And I honestly feel that we all in the room are onto something that's greater than all of us together. And we just have to just keep moving on. And the fact that I would say the majority of the hospitals are with us, right? We have maybe 5% that are not with us. I think that they'll end up coming on, right? They'll ultimately sign on to what we're
Take
doing.
a reasonable size.
I can just not mention my recent experience in Hungary. Last week I was participating at a conference where we discussed stroke. It was a national conference for neuroradiology in Hungary. I went there to give a lecture on how to treat stroke and how we put the patient on the table in 30-45 minutes. And last Tuesday when I was there, one of my family members suffered a large vessel occlusion, left MCA stroke.
While you were there.
While I was there. All what I could do, I couldn't travel there because they were not physically where I was, but I depleted my SIM card in my cell phone. I made hours and hours of phone calls. And I realized that in theory, all those people are very smart and they know what to do. But the organization is terrible. What went well actually, the first 15 minutes, by the time EMS took the patient to first hospital, which was not a stroke center, and from there everything just collapsed. Eventually he got TPA at 4 hours and 25 minutes. And then with the help of God, he became much better, and actually now he's walking and talking and everything is going fine. But that reminded me that next year in Budapest, there will be the WFITN conference, which is a world neurointerventional conference. And by the way, during the lectures, I heard that one word that maybe we should talk to EMS guys. And that's when I realized the need of teaching those guys over there, and not only there, but in the whole world. There was a lecture from Sweden. And it was almost the same catastrophe what happened to my own family member in Hungary. And I'd like to ask one of the EMS directors from here if they are interested. Let's try to write up something about our cooperation here to show how it can be done. And let's travel to the international worldwide meeting to Hungary. I will be the host. I will be a good host. I promise.
I'll be there too.
And let's give some lecture, because really what we are doing here is we are spearheading this stuff.
So what I'm hearing is that Laszlo's funding the trip to Hungary.
Honestly, I thought about asking a company who could provide some support to the traveling and so, but
perhaps we collected some data first.
Well, and I think we have to inject a note of humility, because the problem is, this is all fine and dandy when you have 6 million people within 60 miles or so, all sitting on top of each other where you really wouldn't want to live otherwise. The rest of the world lives spread out in small villages, miles and miles away. And this direct triage to an interventional center is not feasible, because there literally isn't one in the next 50, 60 miles. And you have to have all these patients be driven for an hour or so, literally on the ground.
That's right.
So what we have not determined, and that's on us over the next 1 to 2 years to determine, is where is that break-even point?
Yeah.
Where do you stop taking to the nearest comprehensive center? Or where do you make a difference? And we don't have that answer. And I think that's what we need to develop.
Yeah, I will tell you that we have actually, Rajesh didn't mention his data, but I'm actually presenting the data from Memorial Experience in January in NAMSP. I presented in Stanford a few months ago. But do you want to mention the next year and the 4 different quarterly sessions that we're going to have, kind of working group?
Okay, so for 2017, we designed a series of 6 lectures starting January 12th. And these lectures will be held not in a nice restaurant like this, but at a cold and how could I explain? Smart place, which is Porsche West Broward.
Nice.
they offered us free accommodation, free internet, free everything, except we need some company support for food and beverages for these meetings. That's really minimal compared to what's going on here. And let me quickly go through what we wrote up so far. So January 2017, I thought about talking about pre-hospital management, and that is mostly EMS, the race score system, the other score systems, pre-notification system, transfers, BSC to CSC, or in some cases CSC to CSC, and what happens if a hospital is unable to accommodate patients, so there is a need for diversion and things like that. And so part of the I would say 50-50 didactic and a few great case presentations no longer than 5-10 minutes, and just one interesting case from every person. I will collect those cases and I will organize them into a lecture. Please be aware that YouTube or Facebook will work much better than here, so don't put HIPAA non-compliant data on your slides whenever you prepare anything. So that was for January.
Do we have an actual date set up for that yet?
Yes, actually I do.
Okay.
It's basically every second Thursday of every other month. So January, March, May, and so on, every second Thursday,
And
5 p.m. to 7:30 p.m.
Perfect. I think it deserves to mention that this was an open meeting to everybody. I think that are these meetings going to be the folks who are who are actually participating only? Is that how we're going to make that, or?
What do you mean participating?
Or not? In other words, people who are in the AHA, the Go the Guidelines, and the Puerto Rico Registry, or is it
No.
open?
No,
It's open to everybody.
No, open, and actually I plan to broadcast it.
Oh, good.
Not only to interested parties in Florida, but all over the world. We can actually, I thought we can advertise that anyone can join, because it's
The goal, though,
World Wide Web.
The goal, though, is to, over the next 12 months, to kind of demonstrate best practices, hear what's going on with other folks, so that those hospital systems can then take it back and then utilize or maybe modify what they're doing.
That's our goal.
That's the
to
goal.
bring up every hospital systems up to speed in our area, and if we can influence someone else, that's just an additional benefit.
Right, so I think that the message to everybody here in the room is that the purpose of these meetings is really, it's almost like a workshop.
Education.
Right, so how are we choosing who's speaking and what the topics are? Because I think that everybody in the room should probably participate somehow or another. So how have you determined who's going to be giving the talk and what the talks are about?
Well, again, every meeting will have a different topic. The March meeting is pre-CT triage. The May meeting is acute stroke imaging. July, IVTPA. September, catheter intervention in acute stroke. And November, neuro ICU care of acute stroke patients. And as you see, these are all different topics. We will find those people who are the best for those actual topics.
So how does everyone in the room here?
In fact, I already have some cases for the January meeting.
Okay. So perhaps if someone. Okay.
I will be organizing all 6 meetings. The benefit to that all meetings will be at the same place, the same time. It's for me because the AV.
It's just the second Thursday?
Every other month,
Okay.
5 p.m. through 7:30 p.m. There is a little hiccup because Dr. Harris decided to piggyback on our January meeting.
Any thoughts on that?
If you have any ideas, any thoughts, any modification, email me.
Effort, by the way, we're
One thing I just want to talk about, what we're trying to do, and it's admittedly a very small area in Hialeah, is with EMS and what we're trying to do, we look at soon which we call 9, want to go to a monthly rotation in all the fire stations. We sit on one side of the table and have it as a community event where the whole community is invited. We actually want to bring all for that fire station specifically, bring all the embolectomies or even IVDPA is done for that much period. So it's going to be an ongoing rotation all the time. So in the last 12 months, let's say how many have we brought from that area, and then ask them, look at the positive outcomes, negative outcomes, identify what caused it. Was it a delay 911 call? Was it the fact that I could not open a vessel? Was it the fact that you did not have rehab or whichever? And then kind of use that as a thing for community education. I mean, because it's basically not just, and I guess, our area, Miami-Dade, specifically the western Miami-Dade, has too many other problems with managed care and the way they operate, where I'll tell you for a fact that managed care has been insisting that patients do not call 911 if they're having a stroke. Come to us. And that's been a problem because what they see is for every 10 patients who have a stroke or who have stroke-like symptoms, 6 of them end up not having a stroke. And they lose money in that. So they want to use that as a triage mechanism where they say, come to us. And I've had patients who then finally come to me and they'll be like, oh yeah, I was at this clinic. They called me there. And now, they sent me here because now I'm having a real stroke. And so I've even done embolectomies. I mean, so it's been that bad where that bad a stroke has actually gone to almost like an urgent care clinic. So in that sense, so that's why the education component also is very important when we look at the overall picture of how we improve a system of care. So it's something which we can also look at in Broward. I mean, I'm sure that everyone is not as educated in just even embolectomies or any kind of advanced stroke metrics that we talk about.
The good news is that a large portion of the large vessel occlusions that are not wake-up strokes do call 911. But in the Florida Puerto Rico registry, the average time between last known well time and 911 calls is 6 hours. A lot of them have strokes and things like that. So that's not just a large vessel occlusion, but it's still supportive of what Ritesh says, that you have to have more community education on strokes.
So, in your mind, who's responsible for that education?
I mean, I think it's all of us. But I mean, it cannot happen without EMS's help. I mean, I think all of us have to get together. We have to come up with some kind of a plan. We have to get media involved. We have to get whatever. I mean, the past campaign is too old, I think. And something needs to be more evolved than just the past campaign, which is dying off.
Because if you look at the whole time spectrum, if you shave off 5 or 10 minutes and you're penalizing arguably your hospital for 5 or 10 minutes, aren't you almost barking up the wrong tree because you're losing 6 hours on the other end? Right. So that's really what we need to look at. We need to have a good understanding of where the return of investment is.
It's actually an interesting commentary because we are teaching our medics that a stroke alert is the equivalent of a trauma alert. Trauma alert, we stay 10 minutes on scene, done. And with stroke alert, we're trying to almost tell them the same thing, that it's rapid diagnosis.
Patients and their families don't recognize the same sense of urgency.
Right.
We actually did this back in Iowa some years ago. We did this tremendous media blitz and a lot of heavy public education. And it actually worked very well for a very short period of time, for about 8 to 12 months. We saw a dramatic change in behavior of people coming in earlier. But unless you maintain it, you continue the educational efforts and awareness. People go back to this baseline. Well, I have some numbness and I don't feel quite right. I'll go to sleep and I'll be okay. Wake up and everything will be okay. And unfortunately, a lot of times it's not the case. People have to equate, the symptoms of stroke to the same thing as chest pain. The urgency, and that's tough to do. I mean, that requires a more sustained effort. And that's beyond my skill sets, my budget. I mean, that's something that has to be done on a much larger scale.
That's an AHA, ASA.
Yes.
it's beyond that. It's actually, the government has to really, want
It's a
to
school
invest
thing.
in this. You have to go to the communities and school, educate the schools, that's the way it's gonna happen.
It's interesting because for cardiac arrest, what they found is that if you educate the 7th grader, the 7th grader is more likely to go home and tell mom and dad than the 9th grader. And so there are people who are now teaching about just basic CPR to a 7th grader, and I just wonder if, we rolled out something in Davie, Florida, where we actually teach people how to do hemorrhage control with tourniquets and so forth. We were the first to do that, and I wonder if stroke has to be in that same category as
I
hemorrhage
think so.
control, trauma,
Yeah.
stroke.
You don't have to reinvent the wheel here. I think it's just adjusting the message,
Yeah.
and redirecting some of the resources. But in terms of the basic concept and how you do it, I mean, it's been done with coronary, disease and with trauma. So I think the same thing can be done with stroke.
I mean, I guess the question is, how do we drive that message? I mean, even the cardiac arrest folks, which I'm a part of on a national scale, are having a difficult time understanding how to get that message out. That just push on the chest message, which is as crazy as it sounds, that's a difficult message to get across. And here, all we're asking for is a phone call.
I think it's much more difficult for a lay person to do chest compressions. You need real determination.
Yes, you do. Right.
For calling 911, it's much less.
I think actually, just going away from doing mouth to mouth and just only chest compression. Boom. It's a no-brainer.
No, I can tell you that we listen to every cardiac arrest phone call that comes in, and the call taker, who is not a medic, who's a trained person, they have a very hard time giving the go-ahead to do that. In Broward County, our call takers are very good at picking up stroke, probably more so than the medic, just by hearing the signs and symptoms of the family member on the line. And so, I think that there's probably some ability for us just to say, from the 911 call, if they can make the 911 call, we can pick up a stroke probably 90% of the time, it turns out. I'm not sure, John, do you know who actually did that study? It was probably 10 years ago that we did a study in Broward.
It might have been through Sunrise.
It was through Sunrise. Right, and they said that what was mostly missed were the hemorrhagic strokes. But strokes in general were picked up by 911 at a rate of 90% of the time.
Well, that's good. I mean, that's very encouraging then.
More so than what the medic would pick up.
Yeah, I mean, for us also, EMS has made more positive calls or more correct calls than our ED physician. I mean, in all honesty, that nobody talks bad about our ED physician. But really speaking, I mean, we've reduced our sensitivity in terms of ED physicians towards calling a stroke alert. So if they see a twitch in the face, they still call a stroke alert. But EMS obviously calls it when they see a clear weakness. So in that sense, having race scores or fast ED and all that, that's why I think it's possible. Right? Because we've actually had more correct calls from EMS than we've had.
So I think maybe just to kind of finalize it, I'll say that because I'm within a group of about 50 or 60 medical directors from across the United States, I can tell you that everybody else is about 2 or 3 years behind us, what we're doing today. And I'm getting calls today about things that we were doing a few years ago. And so I think that we now have a lot of pressure, which is cool, which is good. And we have a lot of pressure to actually show what the right thing to do is. And I think that all the things with Sacco and Pulsera and with all you guys in the room here, I would hope that we end up at a place where we have real data to show what is actually the right thing to do. I think stroke is so nebulous, that's why it's so tough. Cardiac arrest is easy, right? Pushing on the chest, they enter into our database. With stroke, it's very difficult.
First of all, it hurts.
Yeah, and it hurts. Right. That's a good point. That's a good point.
What happened to Ohio was always like the big stroke area.
As far as what do you mean, what happened?
Wasn't Ohio like the big hot spot?
Cincinnati.
Well,
Cincinnati and Cleveland.
Yeah.
UC, University of Cincinnati, and delivery trials.
The Cleveland Clinic, I mean, you know, there's been a big push with these stroke ambulances, the CT ambulances. And now there's companies who are just ramped up to really sell these ambulances to entire communities. Houston, Cleveland.
That's actually part of that. So I think though the difference is what you described. In South Florida, you had this high concentration, very population very close to. So in Cleveland, we're spread out by 25, 30, 50 miles, even reaching out to Pennsylvania. So having that truck roam around and having two of those trucks roam around, helps, but here is a different game.
I think the transport times are short. I can tell you in Palm Beach, our average time to scene is about 6 minutes. In Broward County, about 6 to 8 minutes. I was in Cleveland and I was actually on one of those vehicles and I saw a guy come in who got TPA in the field, and he was moving by the time they got in.
Yeah.
But those.
So I actually wrote the business health practice. So we were having some really interesting findings because you're getting TPA